Well, good morning, everyone, and happy Wednesday morning. And thank you for coming along to our webinar this morning. My name's Shyla. I'm the CEO of Palliative Care Queensland. So on behalf of Palliative Care Queensland, we welcome you to our Palli Wellbeing Education webinar series today for health professionals. I'd like to start by acknowledging the traditional owners of the land of wherever we are today and pay respects to elders past, present and emerging. Recognise anyone who is attending this webinar or viewing this webinar with First Nations heritage, and also recognise any sad news or sorry business that may be happening on the lands and seas around us as well. Palliative Care Queensland's key purpose is that we believe that the way we care for our dying is a significant indicator of the kind of society that we are. Our organisational priorities are that all Queenslanders are able to live every day until their last, are able to have a dignified death regardless of illness, age, culture or location, have access to a supportive social network at the end phase of life, and the choice of quality palliative care. This webinar could not have been put on today without the support of our wonderful supporters and sponsors, particularly PalCare Software Company and our Connecting End of Life Care in Townsville project, which is funded or supported by NQPHN and allows health professionals within the Townsville area to attend today's session for free. Also, our Ambulance Wish Queensland program. This allows QAS paramedics to attend today's session for free as well. Now, everyone is pretty good nowadays at the housekeeping on this, but I'll just go through a couple of little reminders for everyone with Zoom. So sometimes we pivot between Zoom and Teams and other platforms. So just the quick housekeeping around Zoom. So for those that may be unfamiliar or haven't used it for a while, just to point out a few of the key features, there's a Q&A section, recognising everyone is on different devices potentially in this space. So if you're on a desktop, it's down the bottom of your screen. If it's on other devices, it may be located in a different area. So there's a Q&A section and there's also a chat function. The Q&A is where you put some questions in after the two speakers have presented, and I'll go through those Q&A questions with them and ask them as many as I can if we have time. You are welcome to pop them up in there during the session and during the speaking time, and I'll ask them after as well. So you don't need to wait if you don't want to. So with the chat function, you also find that on the bottom of your screen if you are on a desktop, and at other locations if you're not. So this is where you can either do a chat to hosts and panelists, or you can do a chat to everyone. So we might just test that out a little bit now and see how that's working for everyone. So we'd love you to send 2 bits of information through the chat function if you can. So firstly, we'd like to know where you're from. And if you could write your suburb or your Aboriginal or Torres Strait Islander land of where you are logging in from today would be wonderful. It's a great way for us to share where everyone is. And you can see we've popped ours there. I'm privileged to be on the Yagara and the Turrbal people's land in the Brisbane area. So we ask you to pop that into the chat function and send that to everyone. So today's webinar. So today we're very privileged to talk about a really important topic around palliative care and homelessness. We have 2 amazing speakers to talk to about this topic today, and I'm very fortunate to hear their experiences, perspectives, and what their organisations do as well. In our annual summit in 2021, we identified this as a hot topic, and we held a round table in this space. We published then the key improvement areas identified out of this, and you'll see this on the screen now, and I'll walk you through these briefly. And you also will put a link up to this document, which is called the Palliative Care in Queensland Priorities. The aim of this is so that the sector and everyone interested in this area, we recognise that we have limited resources, and we really hope that everyone comes together, pulls those resources in the same direction so that we can have some collective effort and see some system change on the key priorities. If we all focus on the same priorities, we're more likely to see change. So that's the purpose of this. So we came up with 7 priorities with regards to palliative care and homelessness. This is to ensure that all accommodation options for homelessness people when they leave hospital. So ensure there is always accommodation options. And we also talked about COVID-19 lockdowns. We want to strengthen compassionate communities strategies as families living in the streets receive support from nurses, counsellors, their communities as well. and as part of a compassionate communities approach. We want to see strengthening the connection between correctional services and palliative care services, and there's some details about that too. We'd like to see understanding the diversity in homelessness and develop strategies for people dying in cars, couch surfing, in hotels, hostels, tents, with no support from their family. I'd like to see improved reporting of deaths of homelessness people, as currently it is underreported. We'd like to see improved spiritual support for people experiencing homelessness. Spiritual care is a critical domain of palliative care, which many people know. And many people may not be religious, but spirituality is still very important in this space, and it creates meaning, making purpose and legacies as well. And we'd like to see improved early access of referrals of people experiencing homelessness to specialist palliative care across Queensland. So these are the key hot topics and the key improvement areas identified. And we'd like to think after this session today, you consider how you can try and integrate this across your services and supports or wherever you work across Queensland or anywhere else, so that you can support that as well. Okay, let's get started. That's enough from me. So I'll now hand over to our first speaker today, who is Leanne. Leanne is a clinical lead at Micah projects, leading an integrated health response to homelessness in vulnerable communities in Brisbane. Leanne's career as a nurse spans 20 years, working with vulnerable communities in London, Nepal, Central Australia, and providing health support to an expedition in Patagonia. Leanne's clinical experience includes cardiac rehabilitation to culturally diverse communities, cardiology, palliative care, alcohol and other drugs, and homeless health. Leanne is also a research student at QUT with her focus on access to healthcare for women experiencing domestic and family violence. Leanne also joins us from a very cold Canberra today, and so we really appreciate you taking the time. She's at the National Homelessness Conference down there. So thank you so much, Leanne, really appreciate it, and over to you.
Thanks so much for having me and for highlighting homelessness and palliative care as a key improvement. Homelessness reduces life expectancy, and it's an independent risk factor for early death, multiplying the risk of early death by between 3 and 7 times. The thought that homelessness is this dangerous and life-limiting should provoke an urgent call to action, but it doesn't. People experiencing homelessness are significantly overrepresented in nearly every aspect of health inequality. Both international and Australian studies indicate that homelessness is strongly linked to morbidity and a significant reduction in life expectancy. Despite these high levels of morbidity and mortality, primary healthcare usage is really poorly accessed, while emergency service usage is high. And there's also data indicating that homeless people presenting to ED departments more likely to present, however, that less likely to remain for treatment. Many homeless individuals experience trimorbidity, which is that combination of physical health, mental health conditions, along with substance misuse. The Brisbane Zero Know by Name list, which is a way we track our rough sleepers in Brisbane, but it also feeds into the Australian Alliance to End Homelessness. And what this does is looks at getting to know the people on our streets, getting to know them by name, getting to know their story. So they're known as people and not just people that are homeless. And when you know their story, you're better able to advocate for them. So the Brisbane Zero campaign is aimed at ending homelessness, because we know people will become homeless, but we want to ensure that it's rare, brief, and non-reoccurring. Because the longer that you are homeless, the more the complexities increase. And the longer that you are homeless, it shows those higher rates of trimorbidity, which is the presence of chronic disease, mental health, and addiction. And trimorbidity then requires an integrated service response across health, social, and housing domains. Yet the delivery of these services that we see at this time are often separated, and that increases the barriers to accessing healthcare. Slide 2. Homeless populations experiencing morbidity, or they experience morbidity at a much younger age. In this Queen study, which is quite significant, it found the average age of homeless cohort to be 42.8 years, and they had comparable levels of morbidity to people aged 85 or greater. And that's really significant, and it's certainly something that we see in the cohort that we work with at Micah. Micah Project's teams have had an increase of people who present with that multimorbidity and requiring palliative care that are living on the streets, in boarding houses, or are vulnerable in social housing. Many of them have only been recently diagnosed, including whilst in correctional centres with no referrals for ongoing health support, whilst others find it difficult to remain in health-funded facility due to inadequate addiction and pain management. Additionally, not being allowed to smoke or have any access to alcohol, people leave prior to formally being discharged from care because they experience stigma and often discrimination to these addictions. And we've certainly seen this around COVID, where COVID-positive homeless population are being discharged to the streets because they have those addictions. They weren't accepted into a lot of the isolation facilities, and that can even include smoking cigarettes. Unless you could go on nicotine patches, they weren't able to be included in those places. And a lot of them do because it's a coping mechanism for trauma they've experienced. People experiencing homelessness face multiple complex barriers in accessing healthcare through the traditional methods. Despite this need, there's many underlying barriers impede the effort to access care. They've got those competing needs. They need food, shelter, there's underlying traumas, previous bad experiences with healthcare providers, a transient nature, no fixed address, and no phone to receive maintenance appointments. And we see that frequently where someone's been referred into hospital for specialist treatment. And we had one fella on a waiting list for bilateral hip replacement for over 4 years. Because you referred in, you've got 1 or 2 chances to have that appointment. If a letter's set out, a text to your phone or a phone call, if you've got no fixed address or no phone, those are easily missed, and then you're sort of removed from the list. You need to go back via a GP back into the hospital for another referral and onto the wait list. Additionally, developing and maintaining a treatment plan for someone that is homeless poses a problem. Keeping medications whilst on the streets difficult, while some medications that may be prescribed cause drowsiness, which can be a danger for someone on the streets because they want to remain alert. Even just something simple, we also have a transgender female with on antivirals at the moment. And the last 3 months, even though there's no street value to those medications, they've been stolen for the last 3 months. So then there's a certain amount of stigma of presenting to request more medications or support to access more medications. And with my research masters at the moment, we're looking at access or barriers to accessing healthcare for people experiencing domestic violence. And what came up as a significant theme in almost every every article that was included in the literature review was that either fear of stigma or being judged by healthcare professionals was a reason not to present to healthcare. So it's really significant with those vulnerable populations. Additional barriers, is that the next slide? Yeah, additional barriers to seeking healthcare might be the cost of travel, the cost of treatment. There's lack of flexibility in appointment times. If an appointment is maintained, a standard appointment is 10 to 15 minutes, and therefore those crisis interventions, such as an infected wound, which is very common on the streets and normally take precedence, and those underlying chronic conditions can often go undiagnosed. Previous homeless studies identified that over 90% of homeless individuals had 2 or more chronic health conditions. They might include mental health, infectious disease, respiratory conditions, and cardiovascular. So managing those comorbidities when you're living in survival mode and having no access to shelter or fridge for medications are all factors that need to be considered. So looking at all of these factors that I've discussed, they're all contributing to early death of people on the streets and the need to transform the way that we deliver healthcare. This includes options for early and fast access to intensive community supports when their health deteriorates, as it does much quicker because often disease is diagnosed later in the process and it's at a much younger age. Challenges to accessing care, that's the next slide there. Increase with the need to navigate complex healthcare systems, and this is further challenged by those internalised barriers such as cognitive, so either dementia, poor health literacy, mental health, poor English, acquired brain injury, and then the emotional factors such as fear and embarrassment. Previous negative experiences due to poorly managed addictions, fear of discrimination, and medication delays contribute to further suffering with those withdrawal symptoms. Sobriety can be often enforced, and policies of zero tolerance for drug and alcohol result in exclusion from housing or required health services. In recent Australian research, 3 in 5 homeless patients, that's 61.6%, had at least one AOD disorder, which is slightly higher than international studies that were linked to either childhood trauma, adversity, or homelessness. Despite this need, the population has poor access to healthcare and palliative care when they need it. Over the past 12 months at Micah, we've seen 23 participants that have died, either prematurely in relation to their chronic disease, overdose, cancer diagnosis, which is often diagnosed quite late, or liver failure, due to not having access to cause of data, which is difficult to find out with our population. We can't have clarity, but we do know the diagnosis and the care that they were struggling to receive before their time of death. Each one of those deaths holds a story of someone that has struggled with a variety of factors that led to their homelessness. Their homelessness further impacting on their physical, mental, and social well-being. This is just over to the next slide now, where I'll share a story of one of our participants who passed away earlier this year. Thomas was a 49-year-old man, homeless, who we first engaged with in 2019 at King George Square after experiencing a housing crisis that was interstate. When we first engaged with Thomas, he had already been sleeping rough for 2.5 years across different states. He came to our attention because of the Brisbane City Council, who we work closely with, as he was unable to mobilise with the sores he had on his feet. Thomas had complex health issues, including epilepsy, gastroesophageal reflux, angina, ischemic heart disease, excessive alcohol consumption, and malnourishment. He'd fallen out of the system altogether, and he had no ID, no GP, no housing, no medication, and no social supports. The street's nurses linked him in to one of the GPs who supported accessing his interstate health records. And on these, it indicated that he did have an acquired brain injury. With these records, we've been able to assist him to apply for NDIS supports and housing. Even with his deteriorating health, though, Thomas would not attend hospitals due to those past experiences of discrimination. When we finally got him in housing, he was still so vulnerable because of his brain injury and his good nature. People would often take advantage of him. And we'd often have our local police officer that we work closely with just to keep an eye on his residence, because people would try and move in. Thomas deteriorated quickly after he was in housing, which we frequently see because you see people deteriorating on the streets and then really get all their information together to advocate for urgent housing. However, that time, and once they get their own space to actually relax, then that's when you sort of uncover everything that was going on for them or link them into more satisfactory healthcare. So he did deteriorate quite quickly, and staff tried to help him with an advanced care directive because he was adamant not to receive any medical care apart from Micah nursing. However, Thomas just wanted to die on his couch, which he was so grateful he had. Despite efforts to link him with palliative care, he died alone on his couch. And whilst it was his wish to die on his couch, he would have preferred not to die alone, as many of our participants would. Micah Projects believes that Brisbane as a city requires the development of respite care options with clinical and social support, providing that continuum of care in home and then through to a respite care where they can access that 24-hour care which you need in those final stages. It's important that such a facility, though, is not bound to Queensland Health. It's already be best managed by an NGO and not by people. Not only do people need that access to adequate clinical care, but also the social support, because people don't want to die alone. The current staffing at Street to Home outreach service and in-home supports doesn't have the capacity when you're at that end of stage life and needing that intensive support to provide consistent care. We do have some good stories, though, as well, when participants we've been able to house and link in with palliative care, and then even work with St Vincent's to be able to sort of provide a last wish before one of our participants died. And it was when we had extra staff on over COVID. So there are those lovely experiences that you're able to facilitate and be there for people, but then there's a lot of those rushed experiences, and it does feel like it's increased over the last year. That was all for me. Thank you.
Leanne, thank you so much. I think putting it into perspective and giving those examples is really amazing, and big kudos and congratulations to what your team does and achieves every day. I think great to propose a sort of solution that's been called for Micah, and I think it's definitely something that our palliative care sector will agree with, and we can work together around how we can advocate collectively in that space. So now I'll hand over to Nick, who's our second speaker for today and a final speaker before we go into the Q&A. Just a reminder to everyone, if you've got any questions, please pop them up in the Q&A area, and I'll ask them to our wonderful speakers straight after. So Nick is the co-founder and Chief Delta Officer, CDO of Orange Sky, the world's first free mobile laundry and shower service for people experiencing homelessness, which they refer to as friends, a lovely concept. Nick is committed to solving problems, innovating and making a difference. This is recognised through his selection as a global leader in the 2019 Obama Foundation Leaders Program. As CDO, Nick plays a key role in ensuring the innovation is at the forefront of Orange Sky's evolution. He leads the technical function and is a key player in the supporters strategy. He plays a critical role in managing Orange Sky's strategic direction. As a member of the senior leadership team, Nick is motivated by Orange Sky's vision and 5-year strategy to help 40,000 friends by 2025. Over to you, Nick. Thank you.
Thanks, Charla. And there's a lot of buzzwords in that that bio, so hopefully I can not disappoint with just some really clear, genuine explanations of what I do. Probably we need to update that bio a little bit. So what a remarkable opportunity it is to share our perspective of what we've seen in this space, but also I think bring it back to a power of a conversation. And I want to acknowledge that conversations and laundry aren't new to Orange Sky. Conversations have been happening here on Jinnaburra country on the Sunshine Coast for over 60,000 years, and acknowledge the power of community and coming together, but acknowledge the reconciliation that needs to continue to happen in all of our spaces to acknowledge those elders past, present and emerging. So probably a bit of a different grassroots story from the amazing research and perspective we heard from Leanne with Orange Sky, but hopefully building on the perspective there from a clinical perspective to a human perspective. So we started Orange Sky in Brisbane nearly 8 years ago with an idea to wash and dry clothes. And the first van we built was named Sudsy, and after a couple of awkward meetings, we convinced a washing machine company to give us some washers and dryers, and took the van out. And what we wanted to achieve, our first mission, was to improve hygiene standards. So rocked up one morning, there was a gentleman sleeping under a shelter in Wickham Park in Brisbane, and woke this gentleman up. His name was Jordan, and said, "I know this is a little bit crazy, but we can wash and dry your clothes." And he did think we were a bit strange, and trusted us with his only possessions in his life, purely out of necessity in the importance of wanting to wash them. So we put Jordan's washing in, and the van completely blew up. And we'd been added to that long list of people throughout Jordan's life that had let him down. So we went back to the washing machine company, convinced them to give us some more washing machines. Went out the next day, again, there was Jordan. And again, for the second day, Jordan trusted us with his only possessions. So chucked him in the machine, and the exact same thing happened. There was a critical error on both the washing machines. And we realized that morning that through Jordan's trust, that Orange Sky was something that really had to happen. So we went back to the drawing board, and we made some technical changes to our hardware, convinced a company to give us some more washing machines, and went out for the third morning in a row. And for whatever reason, Jordan trusted us again with his only possessions in his life, and put Jordan's washing in that left washing machine in our van, pressed the top button and the bottom button, and everything started perfectly. And what we realized that morning is that the mission that we thought we were out there to achieve, which back then was improving hygiene standards, would only ever be a small part of what Orange Sky would ever achieve. We realized that morning that there was absolutely nothing to do except have a chat while the washing was on. And that chat changed my life forever. Jordan went to school just up the road from me. He was studying engineering, which is the exact degree that Lucas, the other co-founder of Orange Sky, was studying. He'd fallen on some tough times. He'd worked for some big firms. He'd made some poor choices and found himself in a situation where he didn't have access to those really basic human rights of shelter, hygiene, but most importantly, someone to talk to. And Jordan talked about how hard it was being disconnected from the community and how those really basic things of shame, stigma, family breakdown had really had a significant impact on his life. So we rewrote that mission at Orange Sky to positively connect communities. And through the simplicity of what Orange Sky does and through the trust and generosity of so many extraordinary people, Orange Sky grew quite quickly. Orange Sky is coming up to 8 years old now. And this, at the moment, we've now got 37 services operating in 25 locations around Australia, or 37 assets. And 4 vans operating in 3 locations over in Aotearoa, New Zealand. So Orange Sky couldn't operate without working with amazing providers, whether it be Micah projects alongside their amazing medical van, or whether it be alongside a religious organisation, or whether it be alongside a school service provider. We add our small piece of value on a really regular and reliable basis to the remarkable work that those community providers do. Orange Sky is now run by nearly 3,000 volunteers that each week go out, put their lives on hold to connect with the community. But volunteering has a massive impact on their life, and I'll unpack that in a tick. And Orange Sky is a charity run purely by donations, and through the trust of donors, we're able to run our service for free, which now also includes shower services. And that sort of random title, which we came up with for my role being the Chief Delta Officer, was a pre-pandemic idea, and it's pretty bad name to have during a pandemic, because I definitely don't come from a health background, so wasn't directly steering our COVID response, even though I had a variant in my title. But what we believe Delta is at Orange Sky is that Greek symbol being an alternate form of change. And what we believe is that within the variables of Orange Sky, being those donors who trust us with their money, those volunteers who trust us with their time, or those friends like Jordan who trust us with their only possessions, how can we continue to create change to help more and more people? And like we mentioned, or like we mentioned in the bio, Orange Sky wants to help 40,000 people by 2025, and we're confident through continuing our growth in our current ways, we'll get there. But how can we accelerate, or how can we do that more sustainably? So one of the avenues that I wanted just to touch on from a friend perspective is sort of 2 years into our operations, we were at a health conference, and Lucas and I were sitting in the back of the room, and a nurse got up on stage and said that there was an epidemic happening in our own backyard, and no one was talking about it. And she went on to talk about the rates of rheumatic heart disease and scabies in remote communities being higher than any third world country. And I can remember being incredibly curious to something that I had completely been not aware of, something so significant in our own backyard. And the amazing speaker continued and sort of said that, you know, this is something that is completely preventable through some really basic things like good hygiene, good healthcare, good education, and laundry. And that got us as an organization thinking about, you know, where could Orange Sky show up? So we then launched a service in the community of Lockhart River in Cape York in Queensland. And what we've done since then is we've now got 11 services operating in remote communities around Australia. And what I always come back to when I think about innovation at Orange Sky is I can remember being on a shift last time I was up in Lockhart River and playing with this young boy Archie. And Archie, you know, had the mischievous, curious, cheeky attributes that I think we all aspire to when we're young. And Ben, who I was with when talking with Archie, kept on taking Archie's photo, and it was sort of became a bit of a game, but it also was a bit strange for me. I couldn't work out why they just for hours kept on taking each other's photos, and then it clicked with me is that Ben was simply just distracting this little boy, because every time Ben stopped taking his photo, Archie went back to scratching the sores on his arms and his legs. And Archie, through scabies, has an incredibly high chance of forming rheumatic heart disease through those infections, and that leading to death. And a few months ago, that couldn't be any more real for me when my grandmother, who didn't grow up in Lockhart River, who grew up in a community only 1,000 k's south, turned 90, and she had rheumatic heart disease when she was a young lady. And if my grandmother had grown up in Lockhart River, wouldn't be here today, or very likely wouldn't be here today. So whether it be people like Archie, or whether it be like Robin over in Perth, who is living in her car, or was living in her car, and came to Orange Sky through the final months of her life in an opportunity to have those really basic things like a conversation, like a shower, like laundry, but not having access to safe spaces to be healthy, and unfortunately passing away through her circumstance. I think we hear so many scenarios of when choice is taken away from people, or when those really basic things are taken away from people, whether that be through a pandemic, like being able to talk to someone. We know time in, time out, that human connection is so important to quality of life. But I mentioned volunteers before, and I think it's something that I always try and share in forums like this, is that yes, Orange Sky is out there to help people who don't have access to really basic things like washers and showers. But now that we have a community of over 3,000 volunteers, what we realize is that volunteers are exactly the same as those friends. A sense of belonging, a sense of community, loneliness, isolation, being sick, dying, is completely relevant to whoever you are, wherever you are, but the circumstance and the approach is different. One of our first volunteers down in Tasmania came to Orange Sky during a new transition in her life. She was finishing up as a school teacher, and wanted an opportunity to give back to her community. She volunteered with her husband, who enjoyed an outing once a week, and they became so involved in Orange Sky that they were running the service in a volunteer capacity down in Hobart. A few months after joining Orange Sky, Ron got diagnosed with a terminal illness, and a few months later to that, unfortunately, Ron passed away. And I can remember talking to the volunteer about that situation, and she told me something that I've never forgotten. She said, even though I have a roof over my head, the nights are the hardest. Losing a life partner, being lonely, isolated, and disconnected in a community. That volunteer used Orange Sky as an opportunity to go out and sit on orange chairs like behind me and connect with people from all walks of life. And she spoke about, friends supporting her in the toughest time of her life, and everyone being on the same journey. And last week, we shared a story of Donna Sturgis from the Central Coast. And Donna was a donor to Orange Sky, but she was also a volunteer, and she was also a friend. Donna left an incredibly generous donation to Orange Sky in her estate. And she spoke about the disconnection and loneliness that she faced throughout her life, and the poor choices that she found herself making led her to a situation where she needed but didn't have access to those things that Orange Sky provided. So through some commitments and some choices that she made, she decided in a different stage of her life to volunteer. And Donna was an active part of our volunteering community through her final stages of life, and then decided to leave a gift to Orange Sky. And again, whether it be a friend, whether it be a volunteer, whether it be a donor, an opportunity to positively contribute to a community and come together is really important. So I guess when we're all thinking about death and the opportunity to, as service providers, provide choice, provide care, I think the main message I wanted to share today, as I'm sure we're all acutely aware of, is that, you know, we're all individuals that are made of the same stuff, and there are some things that are very certain in our stories and our journeys, that one of those being death. And I think that you know, all of our experiences should be unique and sacred to whatever that means to all of us, but as an opportunity to give power to individuals to be in control of that space, whether that be through choosing where you can have a safe, warm shower, whether that be in a bricks and mortar location, whether that be in a van, who you talk to, a sense of community, and having access to those really amazing services, whether that be you know, a service like Micah, who formed the trust of that individual as the only person that they felt safe with. How can we continue to innovate, to find really practical ways to help people? So super excited to answer lots of questions. My puppy Gambino wants to answer one too, and I might pass it back to you, Shyla, for that.
Wonderful. Thank you so much. And yeah, it's just fabulous to hear the stories and the way that this amazing organisation has emerged and making such a difference in so many people's lives. So thank you for what you do and your team does, and everyone around you as well. So over to you guys now for questions. So please pop them in the Q&A area, or if you can't find that, feel free to pop them in the chat area as well. I can multitask and look both ways. So Nick, I see one question has come through for you. So what led to what led you to co-found Orange Sky Laundry? Sorry, Sharon, I got that a bit words jumbled early morning on a public holiday, so sorry about that. But over to you, Nick. So what led you and your co-founder to start Orange Sky?
Yeah, so growing up in school, our school had a food van that went out and helped the community, and I can remember going out on that school food van as a young teenager and not wanting to be there. I was you know, unaware of people in my own backyard that didn't have access to things that I absolutely took for granted. And I can remember meeting a gentleman, Harry, that morning that I still see out on the streets of Brisbane. And Harry was probably in his late 70s back then. He grew up as an orphan in regional Victoria, found himself up in Brisbane on a long journey and not having access to really basic things like community. And I can remember that conversation with Harry just being like a conversation with my uncle or my granddad, except Harry was sleeping on a park bench and didn't have access to those things that I'd taken for granted. So I guess throughout schools, that curiosity and that opportunity to give back was very prevalent. And then leaving high school and going into different careers, something that Lucas and I selfishly missed was an opportunity to give back to the community. So what was a bit of a weekend project, a crazy idea, just because people told us it was impossible to make a mobile washing van, turned into sort of a stubborn determination to give it a go. And I guess that got us to the first Wash Jordan. And I think since then, what we've realized is that if Orange Sky can be trusted by people like Jordan or people like Donna who donate to us, then we're doing a good job. And I guess as another perspective is that Orange Sky's just got over 50 staff that run our organisation, is nearly a $10 million organisation in donations, and the vans go out over 350 times every week. And you know, Lucas and I didn't start Orange Sky to work for Orange Sky. We started Orange Sky to help people. And just as Orange Sky's evolved, we've had to evolve our leadership and our governance. And we're fortunate now to be in a position where Orange Sky is our job, but also know that bringing amazing people on that journey to continue to grow up each year. So the Orange Sky grows about 26%. And what we believe is that whether that be our volunteers, whether it be our donors, whether it be us as staff members, we need to continue to grow to be as appropriately positioned to support our community.
Thank you so much. And it's very inspiring to know that school excursions and school activities can inspire such a great vision. So yeah, I've got young kids, and I think make sure they do some social good in that space for future things. This one's over to you now, Leanne. So whereabouts is Micah Projects? Is it just in Brisbane, or what sort of areas do you cover?
Yeah, so Micah is based in Brisbane, the main office, and there's a lot of different clusters to it. So we've got the homelessness teams, families, Brisbane Domestic Violence Service, which is embedded in that, and the Safer Lives response, where our nurses go and meet with the women in hotels after hours when they're needing a healthcare response. Also with redress, so for those working on those that were stolen generation or forgotten Australians, working through redress, and there's Disability Royal Commission that's going on at the moment. Redress has offices out of Townsville and Rockhampton. We've got a team, Young Mothers for Young Women, in Caboolture, but mostly Brisbane, South and North. With the COVID vaccinations of vulnerable populations, that was extended down to Logan and Bayside, and we've got sort of a home and healthy team working in Logan and Bayside at the moment, which is sort of supporting people to access NDIS with those mental health conditions and providing more intensive support. So yeah, mostly Brisbane, but then spread out in a couple of other locations for specific things.
Thank you. And I think it's definitely something that needs to be more broadly available across the state. And, we're doing a lot of work in the palliative care space to prevent postcode lottery access to healthcare. And I think that's the same for Micah and similar services like that. It's definitely needed all over the state and actually all over Australia and other areas as well. Okay, so now we've got another question. Nick, this one's to you, and well done to everyone. You're giving me one question at a time to each of the speakers, so it's great work. So Nick, do your volunteers encounter many people who have a life-limiting illness?
Absolutely, it's definitely common in our communities, and want to acknowledge that Orange Sky isn't accessible for everyone. We rock up to parks and drop-in centres and have showers inside vans that particularly for people under the age of 18 or with a physical disability isn't fully accessible. And I think what we constantly do through our mission is connect communities. So Orange Sky volunteers aren't doctors or social workers or counsellors. They're everyday people, and their role is to form those connections. But what their key role is to then connect those people back with service providers. So, whether that be basic wound care on a shift delivered by the mobile health clinic of Micah, or whether it be actually helping people get into hospice, or rocking up at a centre where we can just provide community connection, I think is there. But absolutely, it's common. I would say it's more directly and specifically common in remote communities we operate alongside aged care providers and health providers, and also it's very common in major cities where people unfortunately slip through the cracks.
Definitely. And I might just throw an extra one in there because it relates to that. How do you look after your team? Because obviously we all, these are people, and I love the word friends, and in this space, so you do have that natural connection with them. And so we experience, the volunteers, the staff, and everyone experiences grief and loss as well as part of this connection. Is there any specific strategies that you use? And I'll throw to you after, Leanne, with the same question around how you support each other and you support your team, and also other friends experiencing this, in this space. So just a question around that area.
Yeah, I think there's probably no rocket science behind what we do. I think some of those things are very practical. I think also the notion that as humans we all go through different experiences differently, but also I think there's something very beautiful in people supporting each other, whether that be through lived experience or whether that be through the sense of community. And if I think about Ron passing away in Hobart, some of those friends that volunteer helped actually attended Ron's funeral. And that support of on paper it being a one-way street is absolutely incorrect, because that sense of community. So I think people can heal people, and that could be the sense of community. But I also think being very clear with what Orange Sky's purpose and mission is to set boundaries, really good but light touch, accessible, relevant training, but then also access to specialists that Orange Sky is, and then whether that be connecting a friend to a service provider who can help, but also connecting a volunteer with a provider to help them on that journey. So Orange Sky has an EAP program, which we rebranded as a VESP to have the volunteer word in it, and a variety of, whether that be through clinical support to have a conversation, or whether it be just on an orange chair having a yarn, and or the training. I guess there's ways that Orange Sky supports our community, but also is continuing to have to prioritize that in our response.
Lovely, and a great response. I love that people heal people. Great words. Over to you, Leanne, with the same question. How does your team support each other and support those around them that are experiencing the anticipatory grief, which is the fancy word we like to use, the grief before you actually die, and then the grief after as well?
Yeah, I think similar to Nick there, where we've got a good team and a big team that really supports each other, and you can sort of anticipate where someone has been really close with them in the team, and maybe we've had a few deaths in a row, so just being really alert of those needs. We do have external supervision that comes in as well to support staff around that. But yeah, I think it's really therapeutic being able to, like Nick mentioned, support with the funeral or attend the funeral for that closure, or also just being able to share that person's life with maybe lost family members that might sort of make contact after death. So it's really being able to sort of have all those connections and support, like, yeah, everyone in the team and the community with that. Beautiful.
I'll go to the next question now. So looking at, so this one's from Leanne, Lynn asking Leanne. So Leanne, there's two sort of questions within this. It's around the proposal, the shelter, the accommodation, the end of life care, housing that you mentioned that you think would be a great option, especially in the Brisbane area. And then also just, I guess it reflects on the postcode lottery, the north versus south, the different areas that you encounter. We know that from a palliative care perspective, there's a lot of different services based on how the hospital and health service determines how they utilise their funds and utilise their models of care in that space. So how do you navigate that system, and how would you see this this shelter or accommodation look like that you mentioned, the respite accommodation?
Yeah, good question there. I think in terms of respite, like just having the option of where someone can go, because we've got a lot of people that maybe you're working on a plan or working on NDIS supports, but there can be a period of time where they're unable to mobilise or unable to access pain care or treatment, and to have them sort of like not in a secure location with that option of 24-hour support is really difficult for people. So just to be able to have that in a non-discriminatory way where they're going to feel comfortable to have that access and have that support still. The north versus south, I know we've worked with St Vincent's previously, and yeah, we've had a really good opportunity to be able to support someone with that when you've had that little bit more time. We had a older gentleman that had spent most of his life homeless, and we managed to house him over the COVID period when we were getting a little bit of movement on housing placements. But then once you linked him into medical supports, Like he was diagnosed with late stage cancer, but with treatment, we sort of had about 2 months to plan for that, which was a really good opportunity to be able to work with him and with those extra staff on the ground to support him, and having those good connections with St. Vincent's to be able to support his end of life care. He was able to go in and out of hospital, but stay in his home for most of that time. And yeah, that was one of the better experiences we had for the team. And we had 2 of his young support workers supporting him, and because they got to know him so well, they really wanted to be able to help him with one of those end of life wishes, which we tried to line up with the QES via St. Vincent's, which they were a little bit short at the staff, and it was only about a week to go, so they weren't able to grant that. But we said, well, let's try and make it happen anyway with one of the St. Vincent nurses and our 2 support workers. And we said, like, what did you want? Like at the beach, somewhere nice? And he's like, I just want to go back to my home, like, which he'd only just been housed in, and watch a movie with my support workers. So it was just such a lovely experience, that it was just that simplicity and like beauty in his final stages. So he was quite comfortable to go into that hospital experience. So I think it's very individualized of what that person needs. Like, are we able to keep them in their home? But in their home, are we able to have all those extra supports that are able to come in? So you need that combination of having care in the community, but then to escalate to respite when they're not able to have the additional needs. He was quite mobile even up until the last week, so it was a little bit easier, but they're not always ready for hospital or hospice until those latter stages. And then with some disease processes, you just don't know how quickly it might occur. So just having the options of that, but definitely an option of more intensive community supports as a basis before being able to step up. Did that answer that question?
Perfect. Yes, definitely. And a great example there as well. Yeah, it's very individualized in this space. So yeah, really well done. I might just try and group 3 questions together for you, Nick, here around volunteering in this space. So one question is around the latest start time for volunteers to be able to start around work hours. And then there's another one there about what training do your volunteers complete? And another one about what is the rate of staff / volunteer turnover?
Yeah, I think it's looking at the whole volunteer life cycle end to end, which is a really nice question to answer. So I was mentioning, I think earlier, that Orange Sky sort of operates in, if we look at Queensland time, from about 3 o'clock in the morning with our teams over in New Zealand till about just after midnight with our teams over in Perth. So there is a broad range of time that Orange Sky operates from a time zone perspective. However, something that I am really passionate about is that Orange Sky is somewhat a service that is delivered at a regular and reliable time, but also the choice for the end user, being the friend, or the end deliverer, being the volunteer, is sort of decided ultimately by Orange Sky. So we're adding about 7 shifts a month on average that are completely new, and they could be late or they could be early. But what I would encourage people to do is if there's a shift that doesn't work for you at the moment, to still apply to volunteer for Orange Sky, because we're constantly looking at what are people's availabilities and how do we add shifts to respond to those availabilities. And in the future as well, when do people actually want laundry, rather than us just assuming that people want laundry alongside other service providers, which is our delivery model at the moment, and giving a choice back to the individuals, where I get a choice when I want to wash my clothes, and so should anyone in that situation. The second question around turnover, we saw significant turnover through the pandemic, and there was probably a couple of levers to that. One is that people's commitments and work lives changed or people also, their risk appetite changed in how they wanted to engage with the community. We saw throughout COVID, people volunteering prior to COVID. We had incredibly low turnover, and during COVID, high turnover. So we lost 50% of our volunteers through COVID. So people, the Orange Sky, I guess, cohort now is about a 50-50 mix of people that volunteered pre-pandemic and post-pandemic. And I think that if you look at a location like the Sunshine Coast here in Queensland, a lot of those volunteers are actually over 55, and volunteering is more than what we advertise, which is 2 hours a fortnight. Volunteering is a whole day for them, where they get up, they meet their team for coffee beforehand, they pick up the van, they check over the van, they run a shift, and then they go and participate in an activity after volunteering. And so we see very, very low turnover in those locations, because the teams are almost reluctant to let anyone else into their club. So we also see high turnover in some locations as well. So it is something that we're always looking at. How do we provide a right experience, but also as a sector, most people who volunteer at multiple organisations. So how can we then streamline that third question around training and governance over volunteering better? And unfortunately, Orange Sky hasn't always had ideal volunteers, and that might be because we didn't provide enough information around what volunteering actually looks like. I can remember, in the early days, a volunteer saying that this was the laziest volunteering they've ever done, because we were just sitting around having a chinwag. And that volunteer was absolutely right, because from their perspective, they were used to building fences and cooking meals, and we were just literally sitting around having a chat. So we lost that volunteer and wasted that volunteer's time purely because we didn't communicate clearly on what the expectations were. But I guess training is something that we've looked at, learning and development and complex programs, and still backing training as an organisation. But I also think that if you go from a mindset around lifelong learning, online forums like this, we're in a world where, things are changing and we do need to adapt. And rather than specifically providing programs to teach people, we try and build an element of curiosity and resilience in our volunteers to be curious, to provide or to learn more, and then be supported along that journey.
Beautiful. It's such an important role, but it's really important to get it right, isn't it? So yeah, lovely. So we might wrap up now with one question, same question for both of you, which links across to the question that's been asked. So what do you think, from palliative care professionals or health professionals working in this space, what can they do as either an individual or a system to support working with the homeless community or improve working in that space? What's one or two things for each of you? I'll start with Leanne. Not a small question.
I think the option of face-to-face support, often when we've teamed up with Palliative Care in the community, there's been sort of over the phone support where they can titrate pain medication and that kind of thing. But for our participants to build rapport, they really gauge someone by the way they feel when they're in their presence, and it gives them a lot more understanding and then the ability to open up, or whether they can trust them or not. So I think having that option of that in-home face-to-face support and an ability to be able to discuss addictions openly in an environment or a setting, they're not going to feel judged, because often that can affect their pain tolerance, and they might need a lot more pain medication. So just having that understanding of the addiction process and what their needs are around that, because they might still be experiencing pain with that. And then the ability just to have free healthcare in the home when you're in those final stages and needs, because there's so much red tape around accessing aged care because they're too young, or just accessing NDIS in general is very difficult to set up for that day support. So just having someone that can offer that support, intensive support when it's required.
And probably just building on that, I think one of the great things that Project Zero does is doesn't give people a name, that's completely wrong. Doesn't give people a number, gives people a name. And I think that humanizing our numbers or really being connected with our why is so important. And that's what I'm really proud of at Orange Sky, is that it's easy to form a connection when there's nothing to do, because someone is somewhat captive when their only possessions in their life are in a van, and the volunteer can't drive the van because there's washing going on, and constantly looking at how do we respect the privilege to have that community and make sure we never take advantage of that, and how do we curate a really purposeful service. And I only had that situation last week, being out on shift, where I felt like I was passing a burden or a problem onto another organization, and I really empathize with that organization being in a really difficult situation. And that situation was at no fault of anyone. However, it was a fault of, in my view, a lack of really basic collaboration and basic tooling, which is out there. So I think my one thing is, how do we understand and be connected to the individuals that we're ultimately serving, and how do we best use our finite resources to deliver the best level of care, regardless of who's actually delivering it. It's the end individual who needs to be supported.
Oh, well, you two are absolutely amazing. Your teams, your services, what you deliver, what you do, and what you say is completely in line with exactly what our sector is saying at the moment. And it's so lovely to see the connections, the synergies, and the opportunities where we can all work together and really help people, all Queenslanders experiencing serious illness, dying, death, and grief. Thank you for your time, and for everyone who participated today, and the awesome questions that came through as well. It's so lovely to see passion and interest in this space and how we can all work together. And I think the big thing is, it's not just listening to this today, it's around what can we do next? How can we continue this conversation? How can you inspire others? This webinar will be put onto YouTube, and you can share it with other people. And please reach out, start connecting. And if you're inspired to volunteer or do more in this space, please do. So we'd like to thank our wonderful staff and our volunteers for creating and supporting this event. Our beautiful speakers today. How can we, not enough words to say thank you to you both, and thank you for your time, and particularly coming together on a public holiday, and Leanne, when you're down in Canberra at a conference as well. So really appreciate that. Thank you to our supporters and our sponsors in this space. And thank you to everyone, to take time to listen and have those engagement in this space as well. And please take time to reflect and learn and think of what next, so that we can really drive change and do some improvements together as well. So we'll be sending an email out to everyone. It's got one of those evaluation links, so we really appreciate if you could complete that. It's a very short Survey Monkey there. Also, if you'd like a certificate of attendance, please email that to us. Email hello@palliativecareqld.org.au, and we'll send that to you. You'll see that in the email link as well. Like we said, there is a project report or a priorities report you can download, and also to please consider becoming a PCQ member. It's only $75 a year, and it's really around creating a collective voice, so we can advocate collectively on what those priorities are and make some real system and strategic change as well. So thank you all, everyone. Have a beautiful rest of the day, wherever you may be, and thank you again to our wonderful speakers. Please be inspired and keep going in this space, and hopefully we will see that society accepts and understands death and dying is important to all aspects of life. Have a beautiful day. Thank you, everyone.